Okay. Okay, so are we on? Okay, look, I think we better get started. Can I have your attention, please? Thank you. Okay, so this morning we have to do the spinal cord and the spinal nerves, and what I'll do is I'll also talk about segmental supply to the upper limb. Now I know the first part of this lecture is revision, and for the second years it's probably boring revision, but I don't know that it'll do you all that much harm. For the first years I did cover this right back in foundations, so I'm going to start with some revision for you. And we're going to talk a little bit about, just briefly, about the structure of the spinal cord. So you will remember that the spinal cord occupies the vertebral canal, which runs up the centre of the vertebral column. And I'll show you a slide later, but it doesn't extend along the full length of the vertebral column. It varies a little bit by about one vertebral level, but it does extend down as far as the L12 intervertebral disc. Okay, that's on average. Could be one vertebral level higher or one vertebral level lower than that. So it's around about L1 or L2 is where it actually finishes. Okay, now we'll just quickly go back and remind ourselves about the structure of the spinal cord, and you'll remember that it's made up of grey matter in the centre and white matter. Now, this is a cross-section, you've all seen this one before, but basically in the centre of the spinal cord we have the central canal, and you all know now that that's the reason that's there is that the nervous system develops from a tubular cylindrical structure. So this is the remnant of the hollow centre of that tube. Now, the grey matter is sort of H-shaped and it surrounds the central canal, and you might recall that it's made up of a dorsal horn. This, of course, is the dorsal surface, that's the ventral surface there. Dorsal and ventral in the spinal cord are interchangeable with posterior and anterior, okay? But we tend to use dorsal and ventral when we talk about the nervous system. Now, there's also a ventral horn, of course, down here. And then surrounding that, of course, is the white matter. And the white matter I'll talk to you a little bit about later, but that's our white matter here, okay? Which is basically made up of axons of neurons that are travelling up or down the spinal cord, okay? Now, this is a cross-section through the spinal cord. It's stained with myelin, which means that the fibres stain dark and the cells don't stain or stain very palely. Well, they don't stain actually, it's only staining the fibres. So you can see there the structures I've just mentioned, and we do have what is known as an intermediate zone as well, and I'll just put it there as IZ, okay? So that's the bit that's in between the dorsal and the ventral roots, the dorsal and ventral horns, okay? Now, I have actually got a few diagrams here because I didn't want to clutter them all up with just one. So this is actually that's actually the cross-section that you're seeing there. It's pretty close to it. It's from the same level of the spinal cord. And one thing here, if we remember, this is dorsal and ventral. The way that we're going to distinguish the difference between the dorsal and the ventral surface when we look at a spinal cord is that the dorsal surface has what is called the dorsal median sulcus, which is in the midline at the back, but it's very shallow. So when you actually look at the spinal cord, you don't really see much of a groove down the midline. Whereas on the anterior or ventral surface, there's a very deep groove there called the ventral median fissure. Sometimes it's called a sulcus, but a fissure is a deep sulcus. So you can kind of interchange those terms. So that's the thing that really characterises the sort of anterior part of the spinal cord. But sitting within that is an artery. So normally you will see an artery sitting in that fissure and you'll see it running down the anterior surface. That's the main artery supplying the spinal cord, okay? And it's called the anterior spinal artery, and it supplies about 2/3 of the spinal cord. The only part it doesn't supply is a little bit at the back here, okay? But it's also a landmark for identifying the anterior surface there, okay? Now, to remind you now, you remember that the spinal cord is broken up into spinal nerves, or it has a series of spinal nerves coming off the sides of it. There's actually 31 pairs of spinal nerves, and this is just to remind you how the spinal nerves are formed. Now, there is two roots that come out of the spinal cord. Here we have what is known as the dorsal root, and we have the ventral root down here. Now, the dorsal root basically contains incoming sensory fibres. Okay, and you may remember that sensory fibres, so they'll be coming, oh, I don't like that one, it's wrong, we'll use a different colour. Okay, so down here we've got usually there's a specialised receptor on the terminal or on the peripheral end of our sensory neuron, and I'm sure the physiologists will tell you all about those. But basically these fibres go into the spinal cord via the dorsal root. Now they're unique cell types in that they have their cell body located along the course of the nerve, and the cell body actually sits in the dorsal root. And so effectively, and then this part that's bringing information in from the outside, in from the periphery there, because this is what we call a primary sensory neuron, and it's like a modified dendrite. It actually is myelinated, but it's carrying information towards the cell body, okay? We then have, and we often refer to that as the peripheral process of our sensory nerve, okay, or a sensory neuron. And then going in from the cell body, we have an axon. Okay, so that's effectively the axon there, although it's referred to here as a central process, but it's the same thing as the axon. Okay, there is no synapse in this swelling, and this swelling, as you may or may not remember, is the dorsal root ganglion, sometimes called the spinal ganglion. And a ganglion in the nervous system is a group of cell bodies that lie outside of the central nervous system. Okay, so here we have the cell bodies of the incoming sensory fibres clustering there. They are larger than the axons or the fibres, therefore they create a swelling, which we call the dorsal root ganglion. Okay, and because they're incoming sensory fibres, they will largely synapse in the dorsal horn. So the dorsal horn is associated with sensory processing. Okay. Now, our peripheral nerves also contain motor neurons, and motor neurons are carrying messages out to muscle. Okay. And the motor neurons that supply all our skeletal muscles occupy the ventral horn. Okay. And they're big multipolar neurons, and they have a long axon, usually a fairly large axon, and their axons leave the spinal cord via the ventral root. Okay, so the ventral root contains motor neuron axons. And the second years will know that those motor neurons, if any of them are here, if those motor neurons that occupy the ventral horn are known as lower motor neurons. I hope you remember that. Okay, and first years you can put that into your memories now. You'll learn about upper motor neurons at another time. Okay, and then when the motor neurons basically join up, the ventral root joins up with the dorsal root, and they're of course going to go out and supply muscles. So I'll just put an arrow there saying they're going to muscle. Now, the part here where the two join up, and maybe I'll label it on this side, there is our spinal nerve. So the spinal nerve is formed by the union of the dorsal and the ventral roots. Now, the spinal nerves are very short. They exit through the intervertebral foramen, and I'll show you that a little bit later. But the spinal nerves themselves are probably less than a centimetre long. Okay? Because what happens is once they exit from the vertebral canal, they divide up immediately into two rami. Okay, so we have here a dorsal ramus. Hang on, that's meant to be an MUS. And this one here is the ventral ramus of our spinal nerve. Now, both the dorsal and the ventral rami, you can see on this side that the spinal nerve is a mixed structure. It's got motor and sensory fibres in it, information going in both directions. So do both the dorsal and the ventral rami. So I've drawn these here as if they're going into the ventral ramus, but they could just as easily be going into the dorsal ramus of our spinal nerve. The difference is that the area that they supply, and the dorsal rami are quite small, and they supply sensory and motor fibres to the skin and muscles and, vertebral bones, etc. of the back. Okay? So it's skin, muscle, bones and joints of the back region. And it's between just a strip down the middle of the back, which sort of lies medial to what we call the angles of the ribs, where the ribs turn, but it's an area about this wide. Down the strip of the middle of the back. The rest of the trunk, the lateral and anterior sides of the trunk and the limbs are all supplied by the ventral rami. Okay, so they go to anterior and lateral trunk plus the limbs. So they're very much bigger than the dorsal rami, but I guess where the dorsal rami is of relevance is that it does supply the joints of the vertebral column, so that back pain is usually associated with that's the dorsal rami that are transmitting that information. Okay, so on this slide here, you can see that in reality I've drawn it as if there's just one dorsal and ventral root for spinal nerve, but in fact there's a cluster of ventral and dorsal roots that unite to form the spinal nerve. Sometimes these are individually referred to as rootlets, but they will ultimately form, they cluster together to form the root, and then that unites with the dorsal root. And there's the swelling, which is the dorsal root ganglia. Okay, so that's basically the spinal cord structure, and I put this here to remind everybody what they are. The dorsal roots are axons of primary sensory neurons. That's what we call those neurons that go out to the periphery. The ganglion is the cell bodies of sensory neurons, and there is not a synapse there. Okay, ventral roots are lower motor neurons with their cell bodies in the ventral horn. We've got dorsal and ventral rami supplying skin and muscles of different body regions. Okay, so with the neurons that are in there, there are various types of neurons. Now, the one I've just drawn was the sensory neuron, this one here, and then we've got the motor neuron leaving from the ventral horn. Now, within the spinal cord as well, there are lots of what we call interneurons, and they're neurons which have very short axons, so they're just making connections between nearby structures within the spinal cord itself. And then the other type of neuron are these red ones, and these are basically what we would call tract cells. Now, a tract, within the cord, I've defined tracts here, basically there's bundles of very long axons which group together. So they're going to be transmitting information from one region to another, okay? And it turns out that neurons that have similar functions tend to travel together. Okay, and they usually have similar connections. They've got the same target, the same origin. Okay, so we refer to those as tracts. And you will learn about some tracts. I think in this course you might do the spinothalamic, which is actually the one that I've drawn there, but there are several others. Okay, so the tract here that you can see, the cell body, it's going to be a sensory tract because the cell body is in the dorsal horn, and it's receiving incoming information from a sensory neuron. Okay, now that sensory neuron will synapse on the tract cell. Sometimes there's an interneuron in between, depends on the situation, but the tract cell from there has an axon which in this case will cross the midline and then go into the white matter on the opposite side of the cord and then travel up to the brain. So that particular tract that I've drawn there, or that happens to be in this diagram, is the one that I think you will be doing in this course because you're learning about pain. And this pathway that's drawn there is actually the sensory pathway for pain and temperature sensations. And it's called the spinothalamic tract, which means it originates in the spinal cord and it goes to a part of the brain called the thalamus. Okay? So that's the example that I've put there. And it is relevant for you because you will be doing it in this course. Okay, and you can see the fibres cross the midline. They don't always do that for other tracts, but they happen to for this one. Now I've also defined their nuclei. Now you all know nuclei as being, in the centre of a cell, but in the nervous system, we use the term nucleus to refer to a cluster of cells that usually have similar morphology and similar function and connections. They tend to group together, okay? So the cells that you're going to give rise to, say, the spinothalamic tract will tend to cluster together, okay? But we don't need to go through all the details of the tract, of the nuclei in this course, okay? But I tell you, these ones down in the ventral horn are referred to as motor nuclei, surprisingly enough, okay? Now there's also other neurons up in the brain here but I'm not going to worry about those today because we're only looking at the spinal cord. Okay. Oh, I did mention in your notes that there are two other important tracks that you need to know about, but I think you'll be doing them. The second years have already done them, and the first years will do them, I think, next year. But I'll just mention them in passing now. That's the pathway for pain and temperature, the spinothalamic tract, but the incoming sensations for touch and vibration and joint sensations, they don't go to the spinothalamic tract. They form a different tract, which is referred to as the dorsal column because it occupies the dorsal part of the white matter, and that will be a pathway for touch. Okay? And then the other main tract that you're going to need to learn about eventually is a descending motor pathway that goes from the cortex in the brain down to the ventral horn, to the motor neurons, and tells us when to move. Okay? That one's called corticospinal. I won't examine you on those this time, but I just mention them, I put them in your head so that when you hear about them referred to around the traps, you'll know what they're talking about. Okay, and we'll do them in more detail next year for first years. So this is what the spinal cord looks like. We know that's the dorsal surface because we can't see a midline structure. Okay, but you can see all the dorsal roots coming off the side, and there is a sulcus there if you looked at it in cross-section, but it's not very prominent, okay? And these dorsal roots are going to be joining up with ventral roots coming in from the other side. In this particular case, they're covered by the dura mater. We've removed it from the spinal cord, but it's still there covering the dorsal roots, okay? This is the anterior surface or ventral surface of the spinal cord, and we know that because it has a midline structure. You can see this artery running down here. That's the anterior spinal artery. The blue bit behind it is a vein, so there's a vein there as well. And usually you can see those structures running down the centre. And even if they move a little bit off-centre, you can always see that deep groove, which is actually, a couple of millimetres in depth, that ventral median sulcus. So when you see that midline sort of structure, you know that you are now looking at the ventral surface of the spinal cord, and these are the ventral rootlets joining to form a ventral root for the spinal nerve. So, as I said before, and I think you all know, that there are 31 pairs of spinal nerves. There are 8 cervical nerves. There are 12 pairs of thoracic, 5 lumbar, 5 sacral, and 1 coccygeal nerve. And they're named according to the region of the vertebral column where they exit, okay, from the vertebral column. And we define the term spinal segment as the region of the spinal cord which gives rise to the rootlets of one spinal nerve. So if we go back to there, you could sort of draw a line about there and down about there. And so that area there is a spinal segment because it's giving rise to the rootlets to this particular spinal nerve. Okay? So that's how we define a segment. Now you might have noticed there that there are 8 cervical nerves. Oh, first up, this is where they exit. So they exit through the intervertebral foramen, which is between the two pairs of adjacent vertebrae. So you can see here is the body of the vertebra at the front, and then we've got a notch here, which is called the intervertebral notch actually, and there's the vertebra below. And between these two vertebrae, there's a joint here between the articular processes at the front. That's the intervertebral disc there. And between this pair of vertebrae now we have an intervertebral foramen. And that is where the spinal nerve exits. It's also where the spinal nerve forms. You can see on this diagram, they show the dorsal root ganglion there. The ventral root would be coming in just on this side of it, and the spinal cord itself is just the part that passes through that foramen. But the dorsal and ventral roots don't unite until they get to the intervertebral foramen, okay, or just beforehand. Now, the way it turns out, there are, hopefully that there are 7 cervical vertebrae. There are 8 cervical nerves, and the reason for that is that up here, this is the C1 nerve, and that's the C1 vertebra there. so that the C1 nerve actually exits between the C1 vertebra and the skull. So it's coming out above, we would say then that's the C1 nerve is coming out above its corresponding vertebra. This is coming out between the C1 vertebra and the skull, okay? And for the next sort of 7 nerves, they do that. C2 is coming out here between C1 and C2. There's C3, 4, 5, 6 and C7. So C7 there is between the C7 vertebra and the C6 vertebra. Okay, so it's above its corresponding vertebra. The switch where the extra nerve comes in is down the bottom here. There is an 8th cervical nerve, and that emerges between the C7 and the T1 vertebra. Okay, so that's our C8 nerve, and that's the one that throws everything out. Now from that point on, this is the T1 nerve, and it's coming out below its corresponding vertebra. So it's coming out between T1 and T2, and that's the case for all the remaining nerves. They come out below their corresponding vertebra, or through the intervertebral foramen below their corresponding vertebra. Okay, and that's explained quite clearly in that slide. Okay. Now this is just to remind you that the reason that the spinal cord isn't as long as the vertebral column is basically because it reaches maturity before the skeletal system does. Our nervous system has to develop early in the embryo because it's got to sort of drive all the activities within the embryo, and there is a point during development where it is the same length as the vertebral column, and each spinal segment sits opposite. Oh, the spinal segments, I should have said before, are named according to the nerves that they form. So we said before a spinal segment was the part of the cord that gives rise to the fibres of one spinal nerve. So if it's the C6 spinal nerve, it's the C6 segment of the spinal cord. Okay? And it turns out in the embryo, during development, there is a time when the segments actually sit right next to their corresponding vertebra. But what happens is that the spinal cord reaches maturity ahead of the skeletal system. And the vertebral column keeps on growing, but the spinal cord doesn't. Okay? And for that reason, the spinal cord ends up being quite a bit shorter than the vertebral column. Okay? You can see here, they've marked in the first cervical segment, and there's the first thoracic segment, and it's already now sitting above its corresponding vertebra. And down the bottom here is where it ends, and that, I did give you the diagram, you've seen these diagrams before. There is a diagram where we can indicate that on here, with that one. Okay, so on here, this point here represents the end of the spinal cord. Can you see that diagram? No. How do I get it in? I hate this, because it's slow. Okay, there we are. Okay, so this is the end of the spinal cord, which is usually at the L1-2 disc. As I told you before, it can be one level higher or lower than that disc. Okay, and on this diagram, each of those lines represents a spinal nerve. So this is the cervical region there, and that's C1 to C7 nerves. Then we've got thoracic, which is this area here, and that's T1 to T12, because there's 12 thoracic vertebrae. We've got lumbar down here, which is L1 to L5 nerves. And then the very last bit is the sacral part, and there are 5 sacral nerves. Okay, the coccygeal one's down the bottom, and it's a tiny little sort of segment, somewhere around there. So, and on there I've really indicated the location with the lines on the side, or on the spinal cord, indicates where the regions, the segments change. Okay, so that's the end of the cervical segments, and this is the T1 segment. Okay, now, and so what this means is that the dorsal and the ventral roots, which are indicated by these lines here, get longer and longer and longer, okay, before they reach the point where they're going to exit from the spinal cord. And what we end up with down the bottom here is a whole lot of dorsal and ventral roots, because this is L1, say, or L2, but our spinal cord goes right down to the bottom of the sacrum. So the vertebral canal in the sacrum and in the lumbar region of the spinal cord is just filled with nerve roots that are travelling from the lumbar and sacral segments of the spinal cord down to the sacrum to their level of exit from the vertebral column. And those dorsal and ventral roots, to the early anatomists, they thought they looked like a horse's tail. Takes a lot of imagination, but that's what they thought. And this is a dissection here of the spinal cord in situ, and we've basically chipped away the sacrum there. This is where the sacrum should be. And these brown things coming down are those dorsal and ventral rootlets. The end of the spinal cord's about here. Okay? So here are the dorsal and the ventral rootlets for the sacral nerves travelling down and forming a cluster that we call the cauda equina, which translates into English as the horse's tail. Okay? Now, you see the spinal cord there, but in this one here, these are lower limb nerves, and they're really big, okay, because there's a lot of skin and muscle down there for them to supply. And you can see here, there's a swelling here. That's the dorsal root, with the dorsal root ganglion on it for one of our sacral nerves. There's the ventral root coming in from the other side. They've joined up here to form their spinal nerve. And I don't know if this diagram shows it. No. But basically the spinal nerve, as soon as it gets out of the bone there, will divide up into its dorsal and ventral rami. Okay? So the areas that give rise to the nerves for the upper and lower limbs, we'll put it this way, the nerves for the upper and the lower limbs are much larger than the nerves that supply, say, the trunk region. Each of the upper and lower limb nerves is going to supply a larger area of skin, and it's going to supply more muscle fibres. So it's going to have more sensory and more motor neurons in it, and there will be bigger dorsal and ventral horns as well in those areas, okay? So they create what are called enlargements in the spinal cord, and there are two enlargements, and there's a typo in your lecture notes, so I'll point that out. But there are two enlargements. There's one at the top here, and the diameter of the cord does increase in those areas because we've got a much larger amount of grey matter in the centre, okay? So the cervical enlargement is the area where the nerves for the upper limb arise from the spinal cord, and it's made up of the C5 to T1 segments, because those are the spinal nerves that will supply the upper limb, okay? The lumbosacral enlargement exists for the lower limb nerves, and again we've got a much bigger amount of grey matter there, and this is where the typo, I looked at the lecture notes last night and realised that I've said that in the notes, in the printed notes I've given you, that it's L3 to S3. It's L2 to S3, that's a typo, for the lumbosacral enlargement, okay? But you will, and that will be for the lower limb, and you'll do the lower limb nerves later on in this course. We're going to concentrate on the upper limb today, okay? So these are some myelin-stained sections through the spinal cord, and they just show the differences between the enlargements and the area in between, which is the thoracic region. So up the top there, that's the slide you saw, similar to the one you saw before. That's through the cervical region of the spinal cord. And you'll see that the shape there of the spinal cord is different. It's sort of very wide. It's got a wide transverse diameter, but it's fairly narrow AP diameter. Okay? You can see it's got massive ventral horns, and they are supplying the muscles of the limb, and this big bit that sticks out on the side there is actually for the hand muscles, okay, out here, and they have a very, very rich nerve supply. So we have a big ventral horn, relatively, you know, sort of biggish dorsal horn as well. That's made up of sensory neurons. I've called them relay neurons there, but they're really, relay neurons can be tract cells or interneurons. And then down here we've got the ventral horn, which is full of motor neurons, okay? Now, that's the thoracic region. So you can see the relative size of the grey matter. There's a lot less there, and in particular very small ventral horns, okay, and relatively small dorsal horns. I just thought I'd throw that in to remind you that they're in the thoracic region. We've done the autonomic nervous system. The second years should know it well by now. And the first years, I did touch on this in foundations, okay. The sympathetic preganglionic motor neurons arise from the thoracic region of the spinal cord for the sympathetic nervous system. And why I mention that now is they create an extra horn there. So in the thoracic region, there's a dorsal, a ventral, and then a little lateral horn, which is made up of these sympathetic motor neurons. Okay, it's that little bit sticking out there. Now, there's the lumbosacral enlargement. This is through the lumbar part of the cord, and so you can see huge ventral horn, big dorsal horn. These are the cauda equina nerves running down the outside there. They're the dorsal and ventral roots running down the sides. But the difference here between this and that is the amount of white matter. So down at the bottom of the spinal cord, we've got a lot less white matter. If you think about in the cervical region, we've got descending fibres travelling down, motor fibres, to tell the motor neurons what to do. They're travelling down from the brain to the spinal cord, and they leave and go into the spinal grey matter as they get to lower and lower levels. So there's not many of them left by the time we get to the bottom. So there are less motor neurons, and similarly, the sensory tract cells that you saw before, most of those are going to build up as you go up the spinal cord, because down here we're only going to have fibres arising from the dorsal horn there, and they're going to cluster here and travel up, but they're going to add on to they'll get added onto at all levels as they go up, so that tract gets pretty big by the time it's at the top. So we've got more white matter in the cervical region than we do down in the lumbosacral region. Okay. Now, what you can see on the outside there, that orangey sort of thing around the edge there, is actually the meninges of the spinal cord. And you will remember, hopefully you've all done meninges before, that there are 3 layers of meninges surrounding the central nervous system. There's one membrane that actually adheres to the spinal cord itself and to the brain, and that one is called the pia mater. Now there's then a space, and then on the outside of that space we have another layer which is similar in structure to the pia, and that's called the arachnoid mater. And then outside of the arachnoid is this thicker grey layer there, and that is the dura mater. Okay? Now the dura mater is different in structure. It's a very tough fibrous membrane, and it's a protective membrane for the spinal cord and for the brain. Now in the brain, in this cranium, the dura mater actually fuses to the periosteum, which is the connective tissue covering the skull. It covers bones. But down in the spinal cord there's a gap between the dura mater and the periosteum of the bone. And that gap is shown here with fat. It says it contains fat. It actually contains blood vessels as well. There's a venous plexus in there, and it's called the epidural space, which means epi means surrounding. So it's the space surrounding the dura mater. Now girls will know, will have heard of epidural anaesthesia, which is, probably all of you have, which is very common, commonly used during childbirth to anaesthetise the lower part of the body. And they do that because it's safer than giving a general anaesthetic, and they like to keep the mother awake when her baby is born. So when they do an epidural anaesthesia, what's actually happening is they inject the anaesthesia down into the bottom of the spinal cord, up through the sacrum into the vertebral canal, and it diffuses up into the nerves and anaesthetises the nerves as they cross through the epidural space. Okay? There is no epidural space as such in the cranium, not normally anyway. Sometimes one is created by bleeding, but under normal circumstances the dura mater is fused to the bone in the skull. but not down in the spinal cord. The other thing you can see there is that the dura, which is the grey layer, actually extends out over our rootlets, the dorsal and the ventral roots here, and over the dorsal root ganglion until it gets to the spinal nerve, which is here, and at that point it just fuses with the coverings of the spinal nerve. Okay, and that's what it looks like there in a side view. And in this one you can see there's the end of the spinal cord. Okay, this is the vertebral canal down in the lumbosacral region where we have the cauda equina. It's an enlarged area. Oh, I should have mentioned, of course, one of the most important things here, of course, is the subarachnoid space. That's that black area between the arachnoid and the pia, and it contains cerebrospinal fluid. It's often necessary for diagnostic reasons to take samples of cerebrospinal fluid if they suspect infections or bleeding in or around the brain. They may need to take a sample of CSF, and so when they do that, they can take it up here. It's a little more risky up the top there, and the safest place to take a sample of CSF is down below where the spinal cord ends. Okay, down so that you have to go in to this area here, which is referred to as the lumbar cistern. Is it labelled there somewhere? This region here, lumbar cistern. A cistern is just an enlargement of the subarachnoid space. And in there, if you stick a needle right into the midline there, you'll miss, there's no spinal cord there, so there's no risk of damaging the spinal cord, and if you're in the midline, you'll miss the nerves as well because they're going out to the side. So they usually actually go in between the L3 and L4 spines of the vertebrae, or between L4 and L5. And that's why you need to remember that where the spinal cord ends, because you must always go below that. In some people it can go down as low as L3 or L2-3, so you always have to be aware of that, and you take a sample below that level. And they sometimes call them spinal taps. There was actually a movie called Spinal Tap, wasn't there? But that's a spinal tap is what they sometimes call the process of withdrawing CSF from there. Okay? So this is the bottom end of the spinal cord again, but I've mentioned now the coverings. So you can see the cord there has a sort of bluish structure. That's because it's covered by pia mater. Okay, out on the edge here is the dural sheath, and we've actually cut that and reflected it so you can see the spinal cord. And on the side there, the dura forms the outer part of that sheath, and then the shiny inner lining is formed by the arachnoid. Okay, so they're together. And in between would be the subarachnoid space. This is where the spinal cord ends, and you can see that there's an extension of the pia mater that goes down the midline here, and it actually goes all the way down to the coccyx, and it sort of fuses down the bottom there with the coccyx, so it sort of anchors the spinal cord. And that pial extension is called the filum terminal, or the terminal fibre, I guess it is, but filum terminal, and that's just a bit of pia that goes down to the coccyx and helps to hold the spinal cord in place. Now, I want to just talk a little bit about the segmental nerve supply to the upper limb, okay? And when I'm talking about segmental, I'm referring to spinal segments, okay? So it's which spinal segments supply which parts of the upper limb, or which spinal nerves supply which parts of the upper limb. And it's based on the development of the limb. Each spinal nerve, with the exception of C1 actually, C1 doesn't have any sensory fibres in it. All the others do. And the area of skin that a single spinal nerve supplies is called a dermatome. And you know that dermis refers to skin. So dermatome is the area of skin supplied by a spinal nerve, and it's related, the adult pattern is related to the development. So here's the developing embryo, and in the embryo, each dermatome is just basically a ring of skin that goes around the body wall, or around the wall of the embryo. The only problem is that the limbs develop. The limb buds grow out from the sides of the embryo, and as they do that, what they end up doing is that they actually, as the limbs grow, they pull the dermatomes out with them, okay? And so that in the adult, what ends up happening, you can see here that's the C4 dermatome, and then we've got C5, 6, 7, 8, and then T1 down here, and then we've got the ones for the lower limb in green. This is the pattern in the adult. So what's happened to the cervical ones is C2 and 3 supply the back of the head, C4 supplies skin that goes across the top of the shoulders, but then C5 to T1 are entirely on the limb. They've sort of dropped, they've disappeared from the trunk, okay? So what's happened here is that we've got C5, 6, 7, where's 7? That's 7, 8, and T1 going down the limb, and then T2 is back up on the trunk wall, okay? So C5 to T1 dermatomes are the area of skin supplied by those nerves, and they're all on the upper limb, okay? That shows you a dermatome map. What book's this from? I'm not sure which one. I should have marked it. This is probably from Gray's. Now what you'll find is that there are variations in the patterns of dermatomes. And the reason for that, you see these, they call them dermatome maps. And they vary from one book to another. There are various versions of them, and that's because there is overlap between adjacent dermatomes. So say the C5 and the C6 dermatomes, there's C5, here's C6. They actually overlap. And so the boundaries between them are drawn differently by some authors, okay? But non-adjacent ones do not overlap. So across the midline here, for example, C6 does not overlap. That's a clear division there. It doesn't overlap with T1, but it will overlap with the dermatome of the segment nearest to it. Now, the map that I think is the easiest to remember, and it's basically a version of this, is this one. It's easy to remember because if you've got your arm in the anatomical position, okay, C4 is the skin across the shoulder. And then you can go down the lateral side of the limb and back up the medial side. So C5 is the skin of the lateral side of the arm, C6 is the lateral forearm, C7 is the middle of the hand, C8 comes up the medial side of the forearm, and T1 is on the medial side of the arm. Okay, a little bit of T2 extends into the axilla there. Okay, so that's the easiest one to remember. And the C7, they sort of have landmarks, and C7 is actually a critical dermatome because we often have injuries around about that level. And C7 is always the middle of the hand, and the third finger, regardless of overlap on either side, is always supplied by C7, the middle finger. Okay, so it's easy if you just remember 5, 6, 7, 8 and T1, going down one side and up the other side. When I go to my GP, and in fact when I've been into a lot of general practices as an academic as well, you'll find in nearly every single one of them there is a map of dermatomes on the wall. It's bread and butter. It's the sort of stuff that everybody needs to try to remember. Okay? It's really important. Now, there's also, spinal nerves also, there's a pattern of nerve supply to muscles as well. And this map actually comes, it's in various books now, because it's out of copyright I think, but it comes from a book by Last, L-A-S-T, Last's Anatomy, which is a surgical textbook. It's the favourite textbook of the surgeons for anatomy. But it has this schema, which is actually a really nice way of remembering the motor supply to the upper limb. Okay? Now, you can sit down and try to memorise the spinal segments supplying every muscle in the upper limb. It's a waste of brain power. All you need to do is to try to remember this. And I've given you, in your notes, I've given you some sort of conditions there, things to think about. Now, some general rules. Most muscles are supplied by more than one spinal nerve. So the majority of them are supplied by 2 spinal nerves. Okay? Muscles that share a common primary action on a joint all have the same spinal nerve supply. So the flexors of the elbow, which are shown in that diagram there, are all supplied by C5 and C6. You probably know by now that they are biceps and brachialis, are the main ones. They're supplied by segments C5 and C6. Okay? Their opponents So the muscles that perform the opposite movement also share they also have the same, all the extensors of the elbow are going to share the same spinal segment supply. Okay, and usually they run in sequence with the flexors. So you can see here we've got C5 and 6 are flexing the elbow, C7 and 8 extend the elbow. Okay? These are just the key ones to remember. C5 is abduction. The fibres of the deltoid and supraspinatus that abduct the limb are supplied by C5. Okay? The fibres that adduct the limb are supplied by C5, C6, 7 and 8. So they're again running in sequence. Okay? And the other really important ones to remember, try to remember those, and this one here, the elbow, and then down in the hand, T1, which is the small muscles in the hand, the intrinsic muscles of the hand, they are supplied by T1. Okay? So that's the motor pattern. Now, why this is important is if there is a spinal cord injury. Now, if someone has a spinal cord injury, and you can imagine, I think the one I put in your notes is C7, which is not uncommon because where the spinal cord gets injured is where you get a mobile area of the vertebral column meeting up with a less mobile area. So they usually happen at the lower cervical region or the upper cervical. That's head injuries, we'll do that in phase 3. But they often occur at the lower cervical region or at the junction of the lumbar and thoracic sort of region down the bottom here. Now in the upper limb, the C7, the sort of injury we're thinking of here might be a diving accident. Where someone dives into water that's too shallow and their head gets bent forward, or in a rugby scrum when they collapse and the head gets pushed down like that, you can sever the spinal cord. And if the spinal cord is severed, imagine it's severed at C7, what will happen is if you test the sensation, this is when you think about spinal nerve and dermatomes, if you suspect a spinal cord injury. If it's a C7 injury and you tested the patient, you would find that they had normal sensation down the lateral side of their limb, but they would be unable to feel sensation below the C7 segment. So from C8, T1 down, and in your notes I forgot to mention that the entire trunk and lower limb will also be lost. I was just writing about the upper limb. Okay? So a lot of those paraplegics you see around will be able to feel things down one side but not up the other one. They can't feel them from the areas below the level if the spinal cord is cut because the ascending sensory information can't get past the cut. Okay? Similarly, they're going to lose movement. And the movements will be related to these ones here, so that in a patient who has a lesion at C7, they'll be able to abduct their shoulder. Gravity can probably adduct it, but they've also got some C6. They'll be able to flex their elbow, but they won't be able to actively extend it, and they won't be able to move their hand. Okay? So that's where we use these spinal segments and the segmental nerve supply. I mean, it's more important to remember that than it is probably to remember the motor movements. But you'll see it when you actually see patients with spinal injuries. Okay? Now, the only problem now is that that's the spinal nerves themselves. The trouble is that they rearrange themselves. Once the ventral rami, which are going to be supplying the lateral trunk and the limbs, rearrange themselves in the cervical and lumbosacral regions to form what are called plexuses. And the plexus for the upper limb is the brachial plexus, which arises from and brachial plexus is those upper limb nerves C5 to T1. And I think even the first years you saw the median nerve and the ulnar nerve when we did the prac in foundations. Those nerves that we find running down the limb, like the median and the ulnar and the radial nerves in the limbs, are actually a mix of spinal nerves. So the spinal nerves themselves redistribute themselves amongst the nerves of the upper limb. So if you think about, for example, the C6 spinal nerve, you'll have a lecture on the brachial plexus next week, but the C6 spinal nerve actually enters 4 of the 5 main nerves of the upper limb contain fibres from C6. And so what you have to do, I think, to understand the difference between the segmental supply, which is the spinal nerves, versus the peripheral nerve supply, so the limb nerves, probably the easiest thing at this point is to compartmentalise them and say, I'm going to consider the spinal nerve pattern if I suspect a spinal injury or a spinal nerve injury itself, and if there's an injury that's beyond the vertebral column, that's out in the limb itself or in the region of the neck, then you have to think about the pattern of nerves for the upper limb which are formed from the brachial plexus. And Nalini will cover the brachial plexus with you in the next anatomy lecture. The brachial plexus is every medical student's nightmare, but unfortunately, and when we get people back doing surgical training and you say the brachial plexus, and they go, oh, the brachial plexus. But in fact, it's really important because it does get injured. There are injuries all